My name is Jodi Lyons, and I'm the host of Your Need to Know. I'm thrilled to be here today with Dr. Alan Dappen of Doctalker Family Medicine in Vienna, Virginia. Today, Dr. Dappen and I are going to be talking about different kinds of medicine and different types of business plans, if you will, surrounding that. So Alan, thrilled to have you here.
Thank you very much.
You and I have this conversation all the time, so I'm glad we can finally do this on the show.
Yeah.
But one of the things you and I whine about the most is how hard it is to maintain the relationship between physician and patient when the third-party payers are involved and there's a middleman. And so I know that you have a different business model for your practice right now. Can you tell me a little bit about Doctalker and how it's different?
Yeah, so we started a medical practice about 14 years ago that is trying to create a direct relationship with patients. And so what we do is patients, in order to do that, pay us directly for the care when they need care. But fundamentally, we do it outside of the insurance model. By cutting out the middlemen, actually it costs less to deliver care and allows me to do things that are not generally sanctioned or done in a standard business model. For instance, all my patients can call me on the telephone.
Yes.
I can solve many of the problems that way. We can actually get rid of 2/3 of office visits by just patients being able to communicate with me. This allows me also, when people are sick, and if I start a treatment or we do a strategy for what to do, allows them to call me back any instant where something's not working properly.
So it's really doctor-patient relationship, not doctor insurance company, patient insurance company.
Correct. And there's a good metaphor for this that I actually learned through John Guyman, who is one of my mentors in medical school and the head of the department of the University of Washington, which was that what's happened in today's office visit setting under a standard business model is that a patient and a doctor are not any longer seeing each other in a closed room, but it's an open cubicle, and staring into the room and getting all the information from that visit, and that create multiple conflicts of interest are insurance companies and data miners and venture capitalists, big pharma, government. There's a lot of other people who actually have access to the data that's produced in a doctor's visit.
That's a very good point.
And one of the things we've tried to do is make sure that the information that we create inside that office visit is only between the doctor and the patient. And the patient can decide if they want to release any information, but that's up to them.
So it's confidential with the two people who need to know.
Yeah.
Rest only invited in as they need to be.
So we think of it as what do you have to do as a physician to control the healing environment? And those players have alternate goals. So and it's not that they're cruel or bad, but they have alternate motives for being in that room. And so there are times when you might want to invite one of them in, but there's no need for them to always be there constantly.
No, that makes perfect sense. And one of the other things that I personally appreciate as part of your model, and full disclosure, everyone, I'm also one of your patients. I appreciate that you take the time you need. And so how does that work exactly where, I mean, I know you'll spend way more than 10 or 15 minutes with me, and certainly with your other patients. How do you get reimbursed for that?
Well, again, we have a model where patients pay directly for the care. And there are a group of doctors like me in the country, what I will call the conscientious objectors to the standard business model of how healthcare is done, where we're trying to produce very high quality businesses, transparent pricing, and try to get the pricing so that it's not gouging people and they understand what's happening. So this allows, but the current model of what's happening with most doctors is they really get reimbursed for about the first 5 or 10 minutes, maximum 10 minutes of their time. So they only have that much time to get into the room and make a diagnosis and get you out.
Because it's procedure based.
Well, it's driven by certain codes, and the codes can only generate a certain amount of money by diagnostic code, by the way the insurance companies reimburse people. So that creates this drive where doctors spend most of their time inputting data that the insurance companies want and need to justify the charge they're trying to do. It actually is a show in itself to explain what the doctor is doing in a standard office visit. When patients will come in and tell me that when they talk to their doctor, they spent the entire time staring at a screen.
Yes.
That is really worth a 60 minutes expose about what is happening with the doctor and their relationship with the insurance companies and everybody else, and how they're getting this information to give to them for them. And it's just the way they get reimbursed.
But it's got nothing to do with the patient care. It's more of a business transaction.
It's a business transaction. And what happens then too is that if you have a second problem or need more time for counseling, they end up basically having to try to throw you out and bring you back for another visit, because they've kind of maximized the amount of money that you can make in that first 5 or 10 minutes. So anytime after that, they're starting to lose money on you, so they've got to bring you back for another visit.
Well, and that explains why the average Medicare visit is about 11 minutes then. That's probably the reimbursement cap.
Yeah.
But with yours, I know you spend the time, and so that's because you charge by your time? Is that how it works?
Yeah, so exactly. And you know, to be fair, then people will often accuse me, well, you were trying to make this a longer visit so that you can charge more. So
I have not heard that. I've heard the thank God they're listening to me part. But that's
what we try to do, exactly. And so what we do is just pretty much turn on the clock, in essence, when we're working on your medical issues. But there is a lot to creating trusting environments and a trusting relationship. So there's a lot of, if there's moments where we can just turn off the clock and chat about how your family's doing and other issues, there's a lot of time where sometimes we're not actually charging anything. We're just kind of trying to figure out, you know, these people become part of my community. They're part of my friends. They are.
Oh, absolutely.
So it's like, okay, I've figured out what it is you need to do. Now, how's Sally? You know?
Exactly. No, and I certainly appreciate that part. It's less transactional. It's not, okay, here's my elbow, look at it.
Yeah.
So I certainly appreciate that. And so you're different than, and I may be misusing this term.
Yes.
But there's the concierge business model. But you're different from that. Can you explain the difference? First of all, did I use the word right?
You did.
Okay.
And so one of the first groups of doctors who became frustrated about the business model of healthcare, and this happened probably in the 90s at some point, was the concierge model. Physicians started to really resent that they had to mass produce patients. It's called, we call it hamster care, and the doctor's running on a treadmill or on a hamster wheel.
Term.
And you just do this day after day after day, 30 patients a day, turn them in, turn them out, turn them in, turn them out. And it really became frustrating and also demoralizing. Physicians really began to feel. So as a result, there became a lot of disparagement among physicians. To give an example, every survey that's been done among primary care physicians in the last 10 years, large national surveys, every one of them says the same thing. Of the people polled, anybody who's 50 years of age and older, more than 50% say we will quit within the next 3 years.
So the doctors don't want to be doctors
So they do not
anymore.
want to do it. They're burnt out. And it's because of the way this model is built. And they're running faster and faster to keep this pace going so they can get reimbursed by their payers, who is not the patient, it's the insurance company.
No, that makes a lot of sense. It's bad that they're all demoralized, and I know in certain specialties we don't have enough doctors. I'm sorry, what were
So
you
one of the
saying?
reactions then for that, one of the first reactions was, I'm going to create a concierge model.
Okay.
I'm really tired of this running so fast, so I'm going to create a model where I still will accept your insurance, but for an extra fee, which amounts to, usually in these concierge models, about $1,500 or $2,000 in that range.
Per year, right? They just pay that up front, right?
It's an upfront, and then that way you can have my cell phone. I will give you more time. I'll still bill your insurance company for the things that can be done, and I'll bill the insurance company. But this allows me then, as a physician, to only have 500 or 600 patients, so that I can actually so I can give you the attention you need. But what it fundamentally does, and it develops certain reputations. So it does deliver, I think, a superior product, but then it's a much more expensive product
So
as
how
a
are you
service.
different?
So what we do is we don't have any concierge fees. We just charge for time like an accountant, like any other.
Or like the attorneys.
Or attorneys.
Okay.
And it's like a service, like the rest of the service economy usually works on a time basis in some way. Fundamentally, all businesses, time is money. So,
Right.
So I just use that as the metric for saying, now you can police my time, and if I'm trying to overcharge you, you can yell at me. And,
No, that makes sense.
So the concierge, the first doctors to kind of break away and create a wave and get some press and make a reputation for themselves with the concierge model. There's been a whole other sets of groups coming out doing different business practices. They tend to get labeled, and I often get this in my practice, I get labeled as a concierge doctor. Although almost no one, I would guess maybe 2% of the patients in my practice pay me as much as even one concierge membership. Most people pay me up to an hour of time or less, so the majority of our patients end up paying us a few $100 a year.
Now, sitting next to the doctor, watch me cough.
You should see a doctor for that.
Yeah, gee, I should sit here next to a doctor perhaps. So your business model is no Medicare, no Medicaid, no insurance, directly with the patient.
Right. The only person, and in this metaphor of trying to control the healing environment, I sign no contracts with anyone except my patient. And my patient then becomes my boss. So we then can just kind of give the best advice we can. I don't sell anything except my time and my advice. So that I don't sell labs, I don't sell drugs, it's just I'm trying to give you the best advice I can. And try to do what's right and try to get you to the best doctors I know if you need a referral. Where I don't make any profit from anything I recommend. I'm just trying to make sure I do the best job for you.
I certainly appreciate that, and I know how it works. And so when we come back from our break, and we have about a minute before we go to it, but I understand that there's an even newer business model, and I always get it wrong. Direct primary care. Direct primary care.
And this model has just been endorsed by the Academy of Family Practice. So we're finally happy that the large organization and structure of medicine is beginning to understand what we're trying to talk about.
That's terrific. And I have to tell you, what I appreciate most about your practice is the patient really does come first. And there is no middleman. So I certainly like that. I also know many of my colleagues appreciate the confidentiality. You raise a very good point about what the insurance company knows or does not know. And so what I'd like to do before we go to break is tell everybody where they can find Dr. Dappen. He is available at www.doctalker.com, DOCTALKER.com, and he's in Vienna, Virginia. So Dr. Dappen will be heading to break, and when we come back, we will talk about direct primary care.
Perfect.
Thank you.
There's more than just books at the library.
There's more than just books at the library.
Excuse me.
There's more than just books at the library.
Il y a plus que de livres à la bibliothèque.
Hello. You have a lot of great books here today. You know there's more than just books at the library.
I know.
There's more than just books at the library.
Every time I hear the alarm bell go off in school, I think it's an air raid.
A lot of houses in our neighborhood have been destroyed.
I like to close my ears and sing songs whenever the bombs come close.
I'm worried our new neighbors won't like us.
But I know it's all gonna be worth it.
I just want my family to be safe.
But these are not my words.
These are not my words.
These are not my words.
Hey, Hard, what's this? That's my resignation. You're resigning. Why? You've been putting me under a lot of pressure lately. That's why I'm ready to quit. Oh, I forgot. I'll do better. Please don't quit on me.
Don't let your heart quit on you. Get your uncontrolled high blood pressure to a healthy range before it's too late.
everyone. I'm Jodi Lyons, your host of Your Need to Know, and I'm thrilled to be back here with Dr. Alan Dappen of www.doctalker.com, Doctalker. I get it right every now and then. So thrilled that you're here. Before the break, we started very, very briefly talking about direct primary care.
Correct.
Did I get it right? I got the phrase.
DPC.
DPC.
Right.
So can you explain what that is?
So direct primary care is beginning to become a slow and steady movement within the United States among primary care, mostly in the primary care physician group. Mm-hmm. They are trying to create first of all, most of us who do primary care are strongly biased that it is the backbone to creating good health care in the United States.
Absolutely.
And that you have to have a healthy and vibrant primary care community of physicians and caregivers who provide probably 85% of the medical problems in the United States can be handled by a competent primary care physician. So,
yes. You know, I call it the invasion of the ists.
Yes. So it's not, the ists are very important. Mm-hmm. All those specialists are critical.
But somebody has to be orchestrating the
there's been a slow, there are a lot of good studies that document what happens if you don't have enough primary care physicians, which is that costs go up and all the specialist care being divided and subdivided among specialists, that your care outcomes go down as a group, and the cost goes up.
Well, I always say it's like having an orchestra with no conductor.
It's something like
Somebody has to be in charge, yes.
So so as a result, what's happened is the physicians, a group of them are beginning to say, how do we provide and take control of our profession and of the healing environment? So how do we do that? And the DPC is the largest direct primary care movement, is the one that's getting the most reputation. Again, we're trying to differentiate what this is compared to concierge medicine, which is fundamentally, it is a non-insurance-based product and service. Where we say, if you have a high deductible health care plan, you should pay me directly for the direct primary care of all your typical day-to-day health care. And this will make it so that I can probably keep you from going through your deductible. And you have to have insurance for crisis, for big cost items.
Right.
We do know that the number of people in the United States going up with high deductible health care plans is going way up. And so one of the things is, look, if it's your money and you have to get health care, who is the best person to choose for that care?
I would say your primary care physician would be the first person.
So how would you make yourself attractive? Now, so it's not just your health, now it's your money, and it's your time. So how do you balance those things? And the direct primary care movement is trying to address all three of those issues.
So it starts with patient pays provider directly, without the umbrella of what you would pay for concierge.
Correct. And then that money can then be used as a deductible in many cases for certain kinds of problems that you've had. If once you've gone through your deductible, if for any reason you did go through your deductible, the amount that a lot of the money that you paid towards that direct primary care counts towards the deductible.
Oh, it does?
It doesn't. It depends on state by state. So that's a complicated question. But yes, much of it
of course I asked it.
But anyways, so that's the big thing about it. And how they work is they fundamentally say, based on your age, we are charging you, if you're 30, for instance, they'll say, we'll charge you $30 a month plus $10. So for $40 a month, roughly the amount less than what you'd pay to go to Starbucks a few times, so you will get kind of unlimited primary health care. So I am available to you in an unlimited amount. So at that point, you've paid my fee. And so 40 times 12 is, I'm making $480. And as you get older, my fee goes up a little bit. But for $480, you as a patient get a predictable cost of what your day-to-day health care will be. And then no matter what happens in the year, I'll be there as your primary care physician to do whatever I can to take care of that.
So it's almost like paying you to have you on retainer.
So it's almost like an insurance for day-to-day health care. With the primary care, and in their way, everything that way the direct primary care movement works is exactly my model, except my model is just based on pay me if you need me.
Right.
But you don't get unlimited care under my model. So the strength of my model is if you only need 10 minutes that year,
then you pay for the 10 minutes.
You only pay for
right.
10 minutes. But if you had a year where you needed 3 hours, you're going to be a lot better off being in the direct primary care system. So each model has its strengths and weakness. But fundamentally, we are exactly the same short of the payment model. And so there's one that's called direct pay, that would be my model, and then there's the direct primary care, which is a monthly fee, which is not an outrageous fee and a fee that costs a lot less than the concierge model. And the way the direct primary care model works, at least physicians when they're trying to say, this is why I think what I'm doing is very important, is I can give you a predictable cost. Now you don't have to worry about it when you call me for a question. You don't have to be counting the clock or thinking that I'm going to send you a bill. You're already paid for it. So that makes it so you can contact me whenever you want. And I don't get rich from this model. I have to take maybe 700 or 800 patients. And so I get a predictable income stream. I'm not playing games this way. I'm making a certain amount of money. And therefore, you can call me when you want. And this is a group of patients now that I can really focus on and pay attention to.
So it's a smaller patient load than if you were doing insurance.
Yeah, it's a much smaller
probably
patient
a little
load.
bit bigger than the model you currently use.
Right. So one of the big criticisms we have right now in the traditional model, and most physicians would agree with this, is that a doctor who's under the insurance model usually has about 2,000 patients under their panel.
Right.
And almost all of them feel totally overwhelmed. It's all driven through the insurance process, and so one of the interesting questions is what's the ratio? If you have a proper mix of patients through a certain age group,
I was just going to ask
some
you,
of them sick,
what's
some of
the
them
right
not.
number? Yeah.
What's the right number? And no one really knows that question.
Okay.
I've spent a lot of time with Kaiser and Group Health talking to people on this question, and the number that's bantied about is somewhere, it ranges from 800 patients up to as much as 1,600 patients.
Which is still a lot better than 3,000.
Yeah, which is a lot better than what the doctors are under the insurance model. My experience is that going past 1,000 patients makes it hard to focus well on that group.
Well, and to know who the patients are.
So, that I would have said earlier when I started this practice that I probably thought I could take care of 1,500 patients. And I'm slowly realizing that number may not be correct, and it may be more closer to 1,000 patients.
And that number, I assume, also varies depending on the age and the mix of the patients.
That's also true.
So if you had older patients, they would need to pay you more per month, and they'd probably see you a lot more often.
Well, and this is why the model of direct primary care, if you ever look them up, direct primary care, on their website, they do post their prices, and you'll see that there's an age stratification of price to age. So as you get, all of us get more expensive as we get older.
We certainly do, but it seems like this model would work great for younger people who have high deductible insurance plans, that they might need a flu shot or a physical to go play soccer, or maybe catch the flu every now and then.
Right. Well,
so that would work best for them, I would think.
There are some employers that are doing this. They'll, and this is happening especially on the West Coast. A big company called Jodi Lyons has made some good inroads, and they're quite famous in this direct primary care space, having been leaders in this movement. And they have managed to pair insurance and employers, and this makes it so that the employers say, now that you're employed with me, you get your direct primary care. We're going to pay for your direct primary care and pay for Jodi Lyons, which is a monthly fee, and then you have catastrophic health care behind it.
But that makes perfect sense, because it also means that the patients can have a relationship with a doctor, and it's not just hey, I don't feel well, what do I do now? And then they start.
So one of the big tragedies of today's healthcare system is that the make or break question among almost every consumer is, do you accept my insurance company?
I just had this conversation today, literally an hour before we came in here, where one of my clients said, I want to meet a doctor who, when I ask if they're taking new patients, asks what my needs are, not what my insurance is.
Right.
And I said I didn't think we were in any danger of that happening.
So the doctors realize they're not going to get paid. So, and one of the interesting things that's really happened is that because the make or break question is, I've known you for 20 years, I saved your life, I know all your children.
Yes.
You've called me at midnight and I've taken care of you.
Yes.
But as soon as I say I don't accept your insurance company, you're going to leave me as a patient. And so
I think
who
a lot of
owns the
people do.
patient as an economic asset? Who is in control of the patient is the insurance companies.
Right.
That use that wedge to go to the doctor and say, guess what, I'll pay you less.
Exactly.
Because the patient won't come to you unless I can make you do the work for less money. So this is what's led to this trajectory over time of doctors being on the hamster wheel, running faster and faster, because the contracts are, if I don't sign the contract with the insurance company,
Then you don't get that
then
patient.
the patient's not going to come
Right.
back to me. And this has led to this steady disparagement of what's happened in healthcare for primary care.
I understand it completely, and there's a reason I go to you as my doctor. In the last couple minutes we have, you touched on it a little bit earlier.
Yeah.
But one of the things, and we're here in Washington, D.C., many patients are worried about confidentiality. They don't want certain things showing up on medical records. They don't want their insurance companies to know. How do you maintain absolute confidentiality? The insurance companies can say, we want to charge more because you're on X drug or Y drug. How is that different with your business model, the privacy issue?
If you use our practice for your visit, that is confidential, and it doesn't, unless you submit it. If you try to submit that visit to the insurance company to say, I want to get reimbursed for that visit, then the insurance companies want to know what that visit was about.
So they would then see billing codes and things where they can make
and
their own
diagnostic
decision.
codes.
Okay.
And therefore, they're entitled to the note. So every time you let the insurance companies pay for the visit, they get to know what's happening.
But if somebody doesn't submit it and they come to you.
Exactly. So that's one. And secondly, once you start saying, I want labs done, I want medications done, then especially if you're going through the insurance system, then they're going to see those prices. They're going to see those as well. So, they're a very sophisticated system, and they have a national reach. So they're pretty good at knowing what people are doing if they're starting to do. If they're really starting to do, like using insulin, they don't want the insurance company to know they've got diabetes. They'll figure it out pretty soon. So your confidentiality is not is going to be hard to protect in some cases because you need other services in the healthcare system.
Okay, that makes sense. That makes sense. But I do appreciate that you preserve the doctor-patient relationship. Alan, as always, it's great talking with you. And so everybody, again, thrilled to have my guest, Dr. Alan Dappen from Doctalker, www.doctalker.com, DOCTALKER. And I see we have a slide with the correct spelling, the correct website. Again, thrilled you're here. Thank you so much.
Thank you, Jodi.